syndrome, there is always subluxation, homocystinuria, pseudoexfoliation, Weil-Marchesani syndrome, sulfite oxidase deficiency. So these are the factors where you will find a patient with a subluxated cataract. In which cases will be progressive, trauma, ocular surgery, and all that will also cause progressive weakness. How will you manage a patient of a subluxated cataract? It is very important that every patient in the OPD is examined on slit lamp with a fully dilated pupil to prevent surprises on the table. So whenever you find a patient, you have to first investigate as to the cause, whether there was history of trauma, whether it is associated with a rosette cataract, or whether the patient has Marfan's or homocystinuria or any other thing. You have to take preoperative precautions because you have to assess the degree of subluxation and prepare for surgery. Intraoperatively, you will always find that the subluxation is more than what you saw on slit lamp, and post-operative monitoring is important because this is not a straightforward case. So, in investigations, preoperative precautions, intraoperative and post-operative management. So, as we know, the workup includes slit lamp. Nowadays, many institutes, or even if you don't have in your own institute, whether it is whenever it is available to do a UBM to know how the lens is subluxated and its relation with the other ocular structures. B-sans conography is important, where you cannot see the posterior segment when it is a mature cataract for reasons that you need to manage the posterior segment problems also, and for medico-legal purposes. Examination of the retina, because with the cataract being subluxated, there may be associated retina problems which need to be tackled either at the same time or later on, but the patient should be made aware of this. Otherwise, it leads to an unhappy patient. So, preoperative counseling of the patient is extremely important. An unsatisfied patient is a patient who has not been counseled. We know that even after counseling a patient post-operatively, there will be problems. So it is important. You have to tell the patient that it is might be a complicated surgery, but counseling should be in such a way that the patient does not get too scared and run away, or you should be putting facts in such a way that the patient understands what you are talking about. The potential need for a vitrectomy, because if it is subluxated, there may be a vitreous and there will be a need for vitrectomy. So not only for the patient but for your OT preparation, this is necessary. And the post-operative risk of retinal detachment, cystoid macular edema, if there is vitreous loss. The retinal detachment will require a second surgery and the patient must be made aware of this. And the cystoid macular edema will be important because it may cause diminished vision post-operatively and the need for long-term drops. So what is the intraoperative management? So the tunnel has to be placed away from the area of zonular weakness, but it may not always be possible because you cannot do an inferior tunnel. So you can do a superior temporal or temporal. This is where you can limit yourself, but try and do it as far away as possible from the zonular weakness and in the gradient opposite to it. And you must, that is exactly, you cannot do it in an inferior meridian, but you must try not to jeopardize the surgery, the safety of the patient by doing acrobatics and trying to make an incision where you're not comfortable with. A sclerocorneal incision always allows ease of conversion. So this is in case you are trying to do a phacoemulsification, do a sclerocorneal tunnel, and SICS is a savior in these cases because you may land into more complications. So it may be the surgery of choice. Viscoelastic is extremely important because you are manipulating a lot, and the corneal endothelium is very delicate. It cannot be regenerated. So the cornea has to be protected, because whatever you do, you may have a very good surgery at the end, but if the cornea is damaged and there are severe SKs, the patient is not going to see and is going to be very unhappy. Capsulorhexis is very important, and it is very, very difficult because the capsule has no tension, it is going to be lax. So you have to start it in an area away from the dialysis or the subluxation. Dye helps you in defining the capsule and the use of Utrata's forceps. And one must remember that the lens is subluxated, so the CCC should be centered on the lens and not when you are operating in the center of your diameter of the pupil dilatation, because anyway the subluxated lens, you are going to center it with a CTR ring. So these are the things that must be kept in mind. So as you can see, this is a video where there is a mature cataract. You can see the area of subluxation because you can see the orange glow, and the rhexis is being centered, as you can see, and as I said, on the lens and not in the center of the pupil. So this is very, very important. A very good rhexis and a small rhexis is comfortable to make. If you try to make a larger rhexis, it is going to run away. Here we were successful with a needle, but if you're not successful, a utratas can be safely used. Hydrodissection, one has to be extremely careful in hydrodissection because a large amount of fluid, the fluid may escape and can hydrate the vitreous. So one has to be extremely careful. This step is necessary because you need to separate the nucleus, but small amount of fluid in multiple areas is important. Now, placing the IOL, you have to place the IOL in such a way that the haptic itself is used like a partial CTR ring to expand the bag, and it will help to center the IOL. So there are two schools of thought, either parallel to the zonular dialysis or in the area of zonular dialysis, which ensures stretching and decrease the bag to remain oval. Capsular tension rings are always something which provide, have changed the way we treat subluxated lenses, and they have helped us to do extracapsular surgery with the IOL and not intracapsular surgery. So they have changed our life radically. So there are various types of rings available with various sizes, and you have to choose the size. Before operating, you should know the diameter of the cornea, and then accordingly it has to be chosen. But even if it is a wrong size, it is flexible. It will just it will be overlapping each other. Now it can be used. How do you insert a ring? It can be inserted using a forceps, or it can be used either an ab externo or an ab interno technique. So this we will be seeing in the video. So you can insert it like this. Now you can it is circular. So you hold the other end and you thread it. You pass one part of it under the capsule and you keep on moving it so that it goes inside the capsule. And this eyelet is held with the capsulotome needle and then put inside. So it's a very easy technique to learn, but one must remember that it's circular and you have to thread it in. That is the most important part. So many a times the dilemma is when to insert it. In the video that we saw, it was inserted after the capsulorhexis. Yes, I'll finish as fast as possible. And sometimes you can insert it after nucleus delivery. You can customize it on each case. So in cases where the rhexis is not complete, if there is a PC tear, if there are lots severe zonular weakness, you should not use. We found multiple CTR rings in the vitreous in a patient. So as you can see over here, this is a traumatic cataract. Can I take a minute more, sir? So as you can see, this is a subluxated cataract, and you can see the rosette very well over here, which is an indicator of the trauma and the subluxation which can be seen over here. And to do the rhexis, so which is very, very important. Now here, this is a demonstration case of phacoemulsification, but to show that subluxated cataracts can be managed. So nowadays, subluxated cataracts can be managed very, very easily. In phacoemulsification or in SICS, this cataract has to be separated, gently brought out, so that while delivering the nucleus, there is no pressure in the eye. So that is something that one has to remember. So hydrodissection is used to prolapse this nucleus, which makes it very easy to tackle it and to deliver it out in SICS or to phacoemulsify it in phacoemulsification. So if you are doing this, it may come slightly above the iris plane in phaco, but this is required in SICS. Since I have already shown this video, though it is phacoemulsification, I'll complete the video and you can see the CTR ring in place. You can see the zonular dialysis, very minimum energy should be used. So I think in this patient the CTR ring is put now. Yes, in this patient it is put after the phacoemulsification is complete. In the previous video we saw that it was put earlier, and this is how you thread it. So it can be put before the nucleus management or after the nucleus management. And it expands the bag very well. It, once you know how to put it, it's very easy to put it. The first part going under the capsule is important, and then you have to just thread it. This eyelet has to be pulled, and now either with a needle or with a, this thing has to be just put inside. So once, as you can see, the capsular bag expands and the cortex can be managed. So you have to tease the cortex so that the ring and the bag is not disturbed. So basically you have to post-operatively look for the centration of IOL, the shape of the pupil, management of the vitreous, retina examination. So most important thing is that if taken proper care, they can be managed with very good results. Use of CTR is important, adequate anterior vitrectomy and managing the patient properly and giving very good results is extremely important. Thank you so much.